Welcome to Optic Surgeon, the ophthalmology podcast. This is the deep dive, and today we are plunging right into a symptom that's super common but really demands our sharpest focus: light sensitivity or photophobia.
Absolutely. It's essential stuff, especially for residents, final year MBBS students. Because photophobia, it isn't just being bothered by bright lights. It's
Right.
a really crucial signal. Could be pointing to something pretty serious underneath. Recognizing the nuances, connecting it to other signs, that's vital.
So our mission today is to really unpack photophobia, the presentation, the causes, diagnosis, management, kind of distill it down to the core things you need to know when you see that patient walk in.
Okay, let's start with a scenario. You'll definitely see this. Patient comes in complaining of painful light sensitivity. You notice their eyes red, vision's blurred. Maybe at the slit lamp, you spot some subtle corneal haze, perhaps a few cells floating around in the anterior chamber.
Okay, wow. So right away, that combination,
Mhm.
pain, photophobia, red eye, blurred vision, especially if you're seeing haze or cells, that just screams pay attention, doesn't it?
It really does. This isn't just someone who, forgot their sunglasses.
Definitely not.
It immediately puts you on high alert. You're thinking differentials. Could it be anterior uveitis, a nasty keratitis, or maybe something neurological like a migraine or even, worse, meningitis? It demands a really thorough, urgent look.
Okay, so before we jump into all those causes,
Yeah.
let's just pin down the definition. What exactly is photophobia, clinically speaking?
So at its core, photophobia is discomfort or actual pain that's specifically triggered by light exposure. Could be normal light, could be bright light.
It's subjective then, what the
But
patient feels.
exactly, it's subjective. But importantly, it's distinct from simple glare or just general visual impairment.
And that distinction is really important, right? Because
Yeah.
people mix them up. Glare versus photophobia. How do we separate them?
It's a critical diagnostic point. So glare, that's mainly about reduced vision or being dazzled because too much light is getting in the eye.
Mm.
Think aniridia, no iris, or albinism, lack of pigment, or maybe light scattering inside the eye from cataracts, corneal edema. It messes with your vision, but it's not necessarily painful.
Got it. Glare is more about the light interfering with seeing.
Precisely. Whereas photophobia, that's the painful sensitivity, often triggered by light levels that wouldn't bother most people. It's linked directly to inflammation or some kind of neural hypersensitivity.
So if the patient says the light hurts my eyes, especially indoors,
That's photophobia, exactly. If they say, bright sun washes everything out, I can't see, that leans more towards glare. Pain versus visual disruption is a good way to think about it.
that's really helpful. So the significance of photophobia is it's telling us there's some underlying pathology driving that pain response.
Absolutely. It's rarely the primary problem itself. It's a signpost. And it can point to anything from, relatively benign things like severe dry eye, all the way to those vision-threatening emergencies we mentioned, uveitis, keratitis,
Or even systemic things.
right? Or even life-threatening neurological issues like meningitis, subarachnoid hemorrhage. Understanding the photophobia helps you gauge the potential seriousness.
It forces you to dig deeper. Okay, let's talk mechanisms. How does the body actually produce this symptom? Where's the pain coming from?
There are a few key pathways involved. One of the most common, especially with surface problems, is corneal irritation.
Okay.
The cornea is just packed with nerve fibers from the trigeminal nerve V1 branch. When that outer layer, the epithelium, gets disrupted or inflamed.
Like an abrasion or an ulcer.
Exactly, abrasion, ulcer, infection. It intensely stimulates those nerve endings. And that triggers pain, photophobia, and often that reflex eyelid blepharospasm. That's why corneal abrasions hurt so much.
Okay. So damage on the surface hits those nerves directly. What about deeper inside the eye?
Right. That brings us to anterior segment inflammation. Think uveitis. Here you've got inflammation in the iris and the ciliary body. The muscles in there, the iris sphincter controlling the pupil, the ciliary muscle for focus, they can go into painful spasms when they're inflamed.
And light makes it worse.
Yes, because light makes the pupil constrict. That forces those inflamed iris muscles to work harder, which cranks up the spasm and the pain, like flexing an already sore muscle.
Makes perfect sense for something like uveitis. You mentioned a connection beyond the eye itself, too.
Yes, absolutely. The trigeminal autonomic system is a big player here. It helps mediate photophobia and connects eye symptoms with neurological pathways. Super important in conditions like migraine.
Migraine.
Even between headache attacks, migraine sufferers can have significant photophobia because of this neural hypersensitivity involving that system.
So it's not always direct irritation or muscle spasm in the eye. Sometimes it's more about the brain processing light signals abnormally.
Precisely. And kind of related to that is light adaptation impairment. Normally, our eyes adjust quickly to light changes, right? Dark room to bright sun. But in certain retinal disorders or conditions affecting the cone cells, the bright light vision cells, this rapid adjustment gets messed up. The system gets overwhelmed, making even normal light feel too bright, uncomfortable.
Okay, that covers the how. Now let's tackle the what, the specific causes. Where do we start looking?
Let's start right at the front door, corneal disorders. Like we said, any disruption or inflammation there is a major cause because of that trigeminal stimulation.
So what kind of things should be top of mind?
Urgent stuff first. Corneal abrasion, ulcer, infectious keratitis, bacterial, fungal, herpetic, and definitely acanthamoeba, especially in contact lens wearers.
Always asks about context.
Always. But also non-infectious things.
Yeah.
Superficial punctate keratopathy, SPK, those tiny dots, recurrent erosions, exposure problems if the lids don't close well, neurotrophic keratitis where the nerves are shot.
Wow, lots of possibilities just on the cornea.
Then more. Chemical injuries, UV burns, photokeratitis, welder's flash or snow blindness, even some dystrophies like granular band keratopathy or transplant rejection.
And the symptoms for these corneal issues tend to be pretty dramatic.
Often, yeah. Severe pain, that intense driving photophobia, often a strong foreign body sensation, and significant redness. On exam, you're looking for that fluorescein staining, lighting up the defect, maybe corneal haze, or infiltrates those cloudy spots.
Infiltrates suggesting infection or inflammation.
Right. And often that prominent ciliary flush, that deep red ring right around the edge of the cornea.
Okay, moving a bit deeper into the anterior chamber.
Next up, uveal or anterior segment inflammation. This is where those painful iris and ciliary spasms really come into play, worsened by light making the pupil constrict.
So this is uveitis territory.
Primarily, yes. Anterior uveitis iritis or iridocyclitis is the classic example. But this category also includes inflammation deeper in the uveal tract, like posterior uveitis or even scleritis, inflammation of the white part.
Scleritis can be intensely painful too.
Extremely. Even episcleritis, which is usually milder, can cause some sensitivity. Think inflamed pinguecula or pterygium sometimes. Also, acute inflammation after trauma or surgery, inflammatory glaucomas, even rare things like phacoanaphylactic uveitis.
What symptoms point towards inflammation inside the eye rather than just the surface?
You still get pain, significant photophobia, awfully blurred vision, and redness, but the key differentiators are the signs. Usually a strong ciliary flush, and critically you find cells and flare in the anterior chamber.
The hallmark signs.
Absolutely. Those inflammatory cells and protein floating in the fluid, seen with the slit lamp beam. You might also see KP's keratic precipitates, those clumps of cells stuck on the back of the cornea or synechiae, adhesions between the iris and other structures.
Cells, flare, KP, synechiae, definitely pointing towards uveitis. Okay, let's go further back now. The retina.
Right, retinal disorders. Here, the photophobia is often more about that light adaptation impairment we talked about, related to dysfunction or irritation of the photoreceptors or downstream processing.
So things like
Chorioretinitis, retinitis pigmentosa, RP, acute retinal necrosis, also direct photic damage staring at the sun, laser injury, certain retinal degenerations, or generalized cone dysfunction syndromes like achromatopsia.
and there was that interesting pupil finding mentioned.
Yes, the paradoxical pupillary response. In certain conditions affecting widespread cone function like severe RP, congenital stationary night blindness, CSNB, achromatopsia, labor congenital amaurosis, Best disease, the pupil might actually dilate in bright light instead of constricting.
Whoa. Pupils getting bigger in light when they should get smaller. That's a huge clue.
It really is a very memorable sign pointing towards this category of retinal disease.
What other symptoms or signs might you see?
Besides the photophobia, patients might report photopsia as seeing flashes or shimmering lights, often significant vision loss, especially trouble seeing in bright conditions. On exam, you'd look for specific retinal lesions, maybe need an ERG to test function, and definitely check for those paradoxical pupils.
Okay, from the retina, the signal heads down the optic nerve.
Leading us to optic nerve disorders. Here, photophobia seems to stem from dysfunction or inflammation along the nerve pathway itself. Optic neuritis is the classic example.
Optic neuritis. What symptoms make you suspect that?
Well, photophobia is common, often described along with phosphenes as flashing lights, sometimes even sound-induced photisms, where sounds trigger visual stuff, usually vision loss and, crucially, pain with eye movement.
That pain on movement is key for neuritis, isn't it?
Very characteristic. Other optic nerve issues like different neuropathies or papilledema disc swelling from high pressure can also cause photophobia, sometimes with transient blackouts or vision dimming. And interestingly, dominant optic atrophy can also cause that paradoxical pupil response.
Okay, so pain on movement, vision loss, photophobia points strongly to optic neuritis. What if the problem is just with the pupil itself?
Pupillary abnormalities are another distinct category. If the pupil isn't regulating light entry properly, that can cause discomfort, like pharmacologically dilated pupils, maybe from eye drops, or traumatic mydriasis, where injury leaves the pupil large. Specific neurological things like an 80 pupil, big sluggish pupil, or an Argyll-Robertson pupil.
Light near dissociation.
Exactly. Reacts poorly to light, but constricts okay for near focus. And ansocoria, unequal pupils, can also cause relative photophobia in the eye with the bigger pupil.
So the key is just looking closely at the pupils, their size, shape, reaction.
That's the main thing. Besides the photophobia and maybe blurriness, the signs are right there on exam. Poor light reaction, anisocoria, maybe that light near dissociation.
Okay, let's broaden out now. Systemic and neurological conditions.
Right, this really brings that trigeminal autonomic system link back into focus. Systemic neurological conditions can cause photophobia from neural hypersensitivity or systemic problems hitting the eye. Migraine is probably the most common example here.
Both during and between headaches.
Yeah, ictal and interictal photophobia are well described in migraine.
What about the really urgent non-ocular causes in this group?
Things you absolutely cannot miss. Meningeal irritation. Think meningitis or a subarachnoid hemorrhage. Severe photophobia along with headache, stiff neck, fever, neurological signs, big red flags.
Definitely.
Other neural causes could be trigeminal neuralgia, sometimes post-TBI, and then there are systemic diseases with eye findings. Tyrosinemia type 2, that metabolic disorder causing painful corneal pseudodendrites.
Looks like herpes, but isn't.
Exactly. Xeroderma pigmentosum, extreme UV sensitivity, and lots of congenital conditions. Albinism, aniridia, achromatopsia, CSNB, congenital glaucoma, often presenting with significant photophobia from birth or early childhood.
So photophobia isn't always an eye problem originating in the eye. It can be a brain problem or a whole body problem showing up with an eye symptom.
Precisely. And this is why a completely normal eye exam doesn't automatically rule out photophobia as a significant symptom needing investigation.
Right. Like in pure migraine or maybe very early meningitis.
Exactly. The eye might look fine initially, but in others, like tyrosinemia, you'll see those corneal lesions. Or with albinism or aniridia, the congenital signs are obvious. Symptoms here are photophobia, often with headache, maybe fever, neurodeficits, skin changes.
And lastly, that catch-all category, other ocular causes.
Yeah, this covers stuff that doesn't fit neatly elsewhere. Very common things like simple conjunctivitis, blepharitis, or dry eye syndrome often cause some photophobia, though usually milder than, say, uveitis or keratitis.
Well,
Superior limbic keratoconjunctivitis, SLK, flictenulosis, those little inflammatory bumps, even a simple foreign body or contact lens irritation. Don't forget medication toxicity, inflammation after any eye surgery, hypotony, low pressure, malignant glaucoma. Even IOL-related issues like glare or halos, dysphotopsias can sometimes be felt as photophobia.
symptoms here can range quite a bit. Mild to severe, usually with irritation, redness.
That's right. The severity varies hugely. Signs might just be diffuse redness, maybe some corneal staining, sometimes mild AC reaction, but typically not as dramatic as severe uveitis.
Wow. Okay, that is an incredibly broad differential. From the front surface to the back of the eye to the brain and systemic disease. How on earth do you start sorting through that when a patient presents? What's the systematic approach?
It absolutely has to be systematic. And it starts, as always, with a really detailed history. This is where you start narrowing things down. Key questions. Onset and duration. Sudden hours or days suggests acute inflammation like keratitis, uveitis, or chronic weeks, months, years. Points more to migraine, RP, maybe a congenital issue.
What else is crucial in the history?
Details about the symptom itself. How severe is the pain? Mild ache or hide in a dark room pain? Any vision loss with it? What triggers it? Specific lights, time of day, associated symptoms, headache, nausea, stiff neck, neuro stuff, ocular history, trauma, surgery, contacts, previous episodes, and systemic history, autoimmune disease, recent infections, neurodisorders, congenital conditions.
Got it. Thorough history first, then the examination. What are you looking for?
A full systematic eye exam guided by the history. Start with visual acuity. Is it down? That points towards cornea, AC, retina, optic nerve problems. Then check the pupils meticulously. Is there an RAPD?
Relative afferent pupillary defect. Light swung to the bad eye makes the pupil dilate.
Right. Suggests unilateral optic nerve or severe retinal disease. Or is there that paradoxical dilation in bright light? Anisocoria. Light near dissociation. All critical pupil signs.
Okay, VA, pupils,
Yeah,
then structure by structure.
exactly. Look at the conjunctiva. Diffuse redness like conjunctivitis, or that ciliary flush concentrated around the limbus pointing towards corneal or uveal problems. Then, and crucially, the cornea use fluorescein stain. Reveals abrasions, ulcers, SPK. Look closely for infiltrates those white spots or KPs on the back surface, signaling uveitis.
And into the anterior chamber.
Absolutely must assess the anterior chamber, AC, for cells and flare using the slit lamp beam. Look for a hypopion pus or hyphema blood. Examine the iris lens.
And don't forget the back.
Never. Fundus exam is vital. Look for retinal lesions, optic disc swelling papillema, or optic atrophy.
Okay, so you've done the history, the full eye exam. What if the eye exam looks pretty normal, but the patient insists they have significant persistent photophobia?
This is a really key point. If the ocular exam is normal, but the photophobia is real and persistent, you must strongly consider a neurological cause. Time for a targeted neurological exam. Look for signs of migraine, meningitis, cranial nerve issues. The photophobia might be the main clue to something outside the eye.
What about specific tests? When do you order investigations?
You tailor them based on your clinical suspicion. Suspect infectious keratitis, get a corneal scraping for cultures, worried about retinal function, maybe an ERG, macular issue. Photostress test, systemic cause. Labs ANA, RF for autoimmune, syphilis, TB serology, maybe ESR-CRP for inflammation.
Yeah, and aging.
Definitely. CT or MRI of the brain and orbits is urgent if you suspect neurological causes like meningitis, SAH, tumor, or orbital pathology.
When do you need to get help or refer?
Urgent referral to ophthalmology for any suspected sight-threatening emergency bad keratitis, uveitis, and endophthalmitis. Neurology referral if you suspect migraine needing management, or emergently for meningitis signs.
Act.
Rheumatology if you think an autoimmune disease is driving uveitis or scleritis.
Okay, so diagnosis is a systematic puzzle. Once you've figured out the cause, how do you manage the photophobia itself? Is it just sunglasses and hope for the best?
Definitely not. The absolute core principle is treat the underlying cause. Symptomatic relief is important, but if you don't fix the root problem, the photophobia won't truly resolve, and the underlying condition could cause permanent damage.
Can you give some examples of cause-specific treatments?
Sure. For corneal issues, it could be antibiotics, antivirals for infection, lots of lubricants for dry eye or erosions, maybe a bandage contact lens. For uveitis scleritis, it's often topical or systemic steroids, cycloplegics to stop that muscle spasm, and treating any underlying systemic disease. For retinal optic nerve stuff, maybe managing photic damage effects, steroids for optic neuritis in some cases, monitoring for RP, neurological causes, analgesic triptans for migraine, antibiotics for meningitis, neurosurgery for SAH. Pupillary issues might involve dilute pilocarpine for 80s or treating the neurosyphilis causing an AR pupil. Systemic congenital, treating tyrosinemia, managing glaucoma and aniridia, etc.
Right. Treat the disease. But while that treatment is kicking in, what can you do to just make the patient feel better now?
The crucial supportive measures. Top of the list for pain relief, especially from ciliary spasm in uveitis or keratitis, are cycloplegics.
Like cyclopentolate or hematropine.
Exactly. They dilate the pupil, but more importantly, they relax that spasming ciliary muscle. It provides dramatic relief from that deep ache and light-induced pain, often one of the first things you give.
And the classic advice, sunglasses.
Yes. Good quality sunglasses are key. Polarized lenses are often helpful, maybe blue blocking or graded tints. They reduce light entry and minimize glare. And lubricants, artificial tears, thicker gels are essential if dry eye or exposure is contributing.
Any simple environmental tips?
Yeah, definitely. Adjusting lighting. Encourage even. Diffuse indoor light. Use task lighting instead of bright overheads. Minimize glare from windows or screens. And for conditions with chronic severe photophobia like CSNB or childhood glaucoma, simple shades or hats outdoors make a huge difference.
Is surgery ever needed specifically for photophobia?
Sometimes if it addresses the underlying cause, like a corneal transplant for a scarred cornea causing glare and irritation, vitrectomy for severe posterior inflammation or endophthalmitis, maybe adjusting or exchanging an IOL if dysphotopsias are the main problem being perceived as photophobia.
Okay, before we wrap up, there is one critical high-yield pearl. something you absolutely need to have locked down, especially for exams, for clinic emergencies. All right, let's hear it. The bottom line takeaway.
It's identifying the red flags. You must know when photophobia signals a potential sight-threatening emergency. These are the signs demanding immediate, serious attention. Severe pain, significant vision loss accompanying the photophobia, corneal haze or infiltrate, definite cells or flare in the AC, proptosis, bulging eye, an REPD, or clearly abnormal pupils, fixed, paradoxical, significant anisocoria.
And those flags mean you might be dealing with
Really bad stuff. Infectious keratitis, severe uveitis, endophthalmitis, orbital cellulitis, or those systemic neurological emergencies like meningitis or SAH presenting with meningeal signs, including photophobia.
So photophobia plus any of those red flags means
Action is urgent. Full slit lamp exam, fluorescein staining, check the IOP immediately. Cultures if you suspect infection. Urgent imaging, CT/MRI, if you suspect orbital or neuro involvement. And remember, a normal eye exam with persistent, significant photophobia is still a red flag. It demands neurological evaluation.
don't drop the ball just because the eye itself looks okay initially.
Exactly. The key point here is rapid identification of these red flags is absolutely critical to prevent irreversible vision loss or major systemic complications. Benign causes like mild conjunctivitis or simple dry eye, they just don't typically present with that constellation of severe pain, vision loss, and those specific ominous exam signs.
That's a really powerful pearl. It emphasizes how a seemingly simple symptom needs that full clinical context.
It really underscores the importance of that systematic approach we've been talking about.
So as we finish this deep dive, here's something to think about. How can a symptom like being bothered by light, something that sounds almost trivial sometimes, actually trigger such a complex and potentially urgent investigation across so many different systems, from the very front of the eye right back to the brain? It really highlights how interconnected eye health and overall systemic health truly are.
A complex symptom reflecting a complex, interconnected system. Definitely something worth keeping in mind.
That's a wrap. Stay focused, keep learning, subscribe.